panel discussion. The moderator will be Dr. Rushabh Kothari. Will you ask for your panelists, please? Thank you.
Dr. Sunil, Dr. Sandeep, Dr. Nitin, Dr. Tonse. I think two of them are not there, so no, we have only 3 abstracts and 4 people. Okay, so we will be discussing on the 3 abstracts on supportive care which were presented. We start off with CINV. So as we all know that acute and delayed emesis is something which we always are worried of, and more so patients are worried of while chemotherapy. And once emesis set in, the breakthrough emesis and the psychological or anticipatory emesis is something which is very difficult to break. So if we are very good at management of acute and delayed emesis, that will help us and patients a lot. So starting from Dr. Tonse, how do you decide? So you are giving a chemotherapy regimen, how do you decide which antiemetic drugs are to be given?
Well, it depends on the emetogenic potential of the regimen, so high, moderate or low.
Yeah. So I always find it difficult to remember in which category the regimen falls in.
So basically any cisplatin containing regimen, cyclophosphamide more than 1500 mg per meter square, anything which contains an anthracycline and a cyclophosphamide, carboplatin, AUC4. I haven't seen that much of emetic potential with carboplatin per se, as in with cisplat or AC or cyclophosphamide. Then rarer drugs like streptozocin and other things. Then comes the moderate emetogenic, any carboplatin, then any other combination of cyclophosphamide, ifosfamide with anthracyclines per se. So low emetic potential are other medications.
So there is either a chart which you need to refer to when you are
yes.
But what I wanted to convey is there are some applications available where you just write the regimen and they will tell what emetogenic risk patients falls in, especially when we are using the newer regimens. For the routine regimens, we would have a ready-made protocol, or we are used to the antiemetic regimen.
Yeah.
Right. So let's take one by one. Dr. Nitin, for high emetogenic risk, what is your antiemetic regimen? The complete antiemetogenic regimen generally you give?
Yes, so I mean sort of 5-HT3 plus NK1 with DEXA. Again, sort of from a compliance point of view and from reducing infusional time, we are using the combination where it's available as one medicine as such. The one point I want to bring about here is that if I'm using a combination of immunotherapy with chemo, though we have enough sort of data to say DEXA may not be causing that much impact right now, I'm removing DEXA and using olanzapine as well. So apart from the AC regimens and all where olanzapine is now being used, when I would like not to use DEXA when I'm using a immunotherapy with chemo regimen, I'm removing DEXA and using a triplet combination of HT3, NK1 and olanzapine.
Okay. Do you say, for example, you are giving a cisplatin of 70-75 milligram per meter square? Do you add olanzapine to this group?
Yes, yes.
You add on the
by and large, we are using olanzapine in most patients, especially again with GI malignancies as such, because we know it's an appetite stimulant. But the dose which I think most of us, we are not going to the 5 mg BD dose, either 2.5 mg BD or 5 mg in the night dose. So using a reduced dose olanzapine.
Which makes sense. And Dr. Sandeep, how is your experience with carboplatin compared to the, whether you change anything for carboplatin?
No, carboplatin is actually comes in a moderate, so not much of the actual emetogenic potential. It goes in a moderate, but even if I have seen not much of the emetogenic, even practically it comes in the low, so the same. And as we know, delayed emesis is not particular for carboplatin. For delayed emesis, we are giving olanzapine for and steroid if it is not contraindicated for day 2 to day 4 to avoid, as you already pointed out about the delayed and the anticipated.
So, as I understand from panelists, NK1, 5-HT3, DEX for moderate and high we tend to use olanzapine in patients where we want to either avoid steroids, or sometimes especially when the hematogenic risk is more, or even if we want some appetite stimulant effect, we tend to use olanzapine. We would be liberal in using it, and we would generally dose reduce, will not give 10 milligram per day dose. I think that's fair. Now the first abstract by Dr. Rajesh showed that can we give mirtazapine, which is somewhat similar to olanzapine but probably less sedative. So the abstract showed that without NK1 the response rate or complete response rate was reasonably good. So can we skip that drug and use mirtazapine? So aprepitant, this probably is not very applicable to our subset. We don't have very costly aprepitant or fosaprepitant or nutipitant. We have reasonably cost effective, but in countries where it is very costly, probably this drug would save. So this was the chart which we discussed on. Yeah, so the ESCO guidelines for cisplatin and AC based has all 4 drugs which we discussed, and olanzapine and dexamethasone are for 4 days and aprepitant for 3 days. And for carboplatin, the delayed emesis changes. You need everything for first day only, but most of the time with carboplatin you have some other drug and which may mandate usage of steroid for longer duration. So what is your take on the study, the CR rates, Dr. Sunil? Would you be comfortable skipping?
So still, I am not comfortable with skipping NK1 antagonist, especially for highly hematogenic. I think the 4-drug combination looks fine to me, and olanzapine even in low doses helps, like 2.5 milligram HS.
So I think this study would be more important for a country where the NK1 are very costly. Otherwise,
the only other thing I would say of this study is it helps us to replace olanzapine with mirtazapine if someone is having a lot of somnolence, sedation with olanzapine. So I think even with where we are using olanzapine, if the side effects is more, we can possibly extrapolate.
Olanzapine helps in appetite stimulation also, which we don't know whether this would do or not. Right, so we will move on to the second abstract, which was not discussed, and this is an Indian study. So you had partly answered, Dr. Nitin, that in situations where you want to avoid dexamethasone, because if you see complete 6 cycles or beyond cycles, the dosage of dexamethasone cumulative would be reasonably high. So in situations where you want to avoid dexamethasone in high risk antiemetogenic situation, based on the study, so this study had these protocols: AC, cisplatin with radiation, cisplatin without radiation, carboplatin based or doxorubicin based. Most of them had AC or cisplatin as a regimen, and we all know that this would categorized as high hematogenic drugs. So what they have done is that they have not given dexamethasone and added olanzapine to otherwise the routine bracket, and the response, complete response to nausea, vomiting and total response, everything was good without dexamethasone also. So the question would be, in patients who are dexa eligible, would you be tempted to skip dexamethasone?
Yeah, we routinely do skip DEXA because a lot of adverse events, hyperglycemia. We see a lot of fungal skin infections in females, which are intractable with topical antifungals. I end up giving oral antifungals. So I prefer to give fosaprepitant or aprepitant or netipitant with the palnosatine combination with olanzapine and try and avoid dexamethasone. There is a retrospective published article by Dr. Suhas Agre et al. And it was a good study. And the CINV CR rates were higher. And I think you can let go of dexamethasone.
I think one situation is, so we were giving for a few patients with advanced head and neck where we were trying to downstage, giving a combination of pembrolizumab with docetaxel 5-FU based regimens, and there when we skipped DEXA, the side effects of docetaxel with the capillary leak syndrome and all was happening. So, and again, possibly with some medicines, it's not just the antiemetic effect, but the other effect where you can't skip DEXA even if you're using. But yes, for example, I'm still not convinced whether I would remove it in AC regimens, because that's some place where I still think that DEXA, when we have skipped DEXA, our patients even on olanzapine have reported the acute emesis to be a little more. So I'm not that comfortable, but yes, most regimens we are removing it now.
So can we say that at least we now have a confidence that in patients where we want to avoid dexamethasone, olanzapine would be a reasonable choice to add on and skip DEXA. I would agree to your points that in situations where we are able to give dexamethasone or dexamethasone is indicated, say, for example, in Texans, you want to give because infusion reactions, capillary leaks. So in that situation, as such also you are going to give. But in situations where you want to avoid dexamethasone, olanzapine can probably take care of.
This study has olanzapine is in both the things. The fosaprepitant was the NK1 receptor has the options. Olanzapine and paltusotine. This CINV POD trial.
Yeah. Olanzapine was there. Dexamethasone was not there in
dexamethasone versus the fosaprepitant. Olanzapine and paltusotine was there in both the arms.
Okay. So I missed that part. What I feel is the regimens were same, only dexamethasone was
No. It is olanzapine and paltusotine in both the arms. Dexa versus fosaprepitant.
Okay. So probably if you want to skip DEXA, you have to give NK1. So that is then probably similar to the Mirtazapine study. Okay. So basically, in situations where you want to avoid dexamethasone, the other background has to be complete, and on skipping dexamethasone, you get reasonably equivalent complete response in nausea, in vomiting, for both acute and delayed. And as per guidelines, we tend to add olanzapine to all three drugs because we had a study showing that there is incremental benefit of giving olanzapine in highly metagenic. This is AC and cisplatin based regimens. So now this is the third abstract where a new drug is given for cancer cachexia. Now this is a very complex problem and difficult to treat problem in day-to-day practice. How do you generally evaluate a patient? Means how would you treat a patient of cachexia, Sandeep? So,
cachexia, it's actually really difficult. There is some data and showing that a patient with the steroids also help, or even olanzapine has some potential for the stimulant. So that we usually use in, or end is like 160 mg. That's also some data shows, some trial shows that there is a benefit. So till now I am using that one. Not upfront, but the first sign of cachexia.
Dr. Sunil, anything else you want to add regarding the abstract which was presented by Dr. Sangeeta? So for cachexia, first thing would be anything which is reversible. We would address that, like dysphagia or nutritional. We do nutritional assessment and supplement whatever is missing, abdominal pain, malabsorption. We address all that, and after that we would probably consider some pharmacological intervention. As you pointed out, corticosteroids, progestins, olanzapine, they have shown some benefit, some with evidence, some with retrospective data, that they do improve. Some would improve appetite, some would improve weight, but most of them are not able to improve muscle mass. So eventually in clinic, olanzapine is something which we now liberally give. Magestrol, as you told, is something which we tend to give, but probably these two are the only pharmacological intervention, and we know in practice it helps in for some weeks or so, but it is not a very easily managed situation. So now this is a drug which has shown a significant improvement in weight, even in 5% weight gain. The 400 milligram dose in most of the patients, it has shown a weight gain of 3 kg or more. So this is something which probably we need to learn, and we need this supportive care. Cancer cachexia happens in very terminal situations, so the cost of the drug whenever it comes is also something which we need to ponder on. But this drug improves weight also, and it causes betterment of muscle mass also, which was not seen with the drugs which we generally use. With olanzapine, we have seen that it improves appetite, but not the cachexia per se. Any other points on cachexia which you want to address, any of the panelists?
I think this study included non-small cell lung cancer and pancreatic and colorectal, but in Indian scenario, what we see routinely, cachexia in head and neck cancer, esophagus and stomach. So I don't know how much pertinent it is for our
in that situation,
patients.
a significant part is the dysphagia or inability to swallowing. So that is probably which we need to address first, and then I think in most of the malignancies in terminal situation, the cachexia sets in, and which we as a physician are also helpless what to do. In first visit we will give olanzapine, in second visit we would give NDAS, and in third and fourth visit probably we will come to know that nothing is helping. So if this drug really helps.
I don't think from an Indian psychology, I think that's something we have all understood. Family will still ask what food to eat. If you tell them that you're going to give an injection to increase weight, they're not going to take. They will still come to, should we make any changes in diet? And that's a practical this thing that is
I would agree that family will always want to add something in their diet and something like that. That's it. Thank you. I think any other. Okay, thank you. Bolo, bolo, bolo. So actually there are studies which have shown that if you are giving the doses which are recommended in antiemesis, the result or efficacy of immunotherapy is not hampered. But as what Dr. Nitin told, you always have an option to replace it with olanzapine and skip dexamethasone for the delayed emesis for the second day, third day, fourth day dose. But based on regimen, you have to take a call. It is difficult. No, so I am giving steroids as per recommendation, anti-emetogenic recommendation with immunotherapy.
So again, if you are using paclitaxel on the day of chemo, it's very important that steroid is not given before the administration of immuno. So there are many studies now which have shown that any usage of steroids for whatever reason, you have asthma patients also who come in, if they have taken steroids before immuno, your T cells are already dampened and they're not going to come out into circulation. So usage of steroids before administration of immuno is a negative prognostic factor along with the usage of antibiotics. In my personal practice, I don't use steroids for most conditions in which I'm giving immuno. I use the regimen of HT3, NK1 and olanzapine, and it's working well, except if I'm using a taxane like docetaxel because of the capillary leak reaction, which when I've avoided in 2-3 patients, on day 2, day 3, they do have a lot of diarrhea, feet swelling and all that. So it is okay to try without steroids when you're using especially paclicarbo, but again, with paclicarbo, I would use not DEXA, I would actually have started using hydrocortisone from a viewpoint of allergic reaction, because there you're worried about the allergic reaction. So I don't use DEXA for antiemesis, but instead, just before giving Pacli, I use 50 to 100 mg of hydrocort.
One more thing I want to add here, the taxanes. There are a different type of taxanes, like the albumin bond or Aquilivs. There they have mentioned that DEXA need not to give. So we can consider using the different type of taxanes rather than the conventional taxanes to avoid the DEXA, and that works.
So with immunotherapy, people would try to avoid dexamethasone whenever feasible. You have olanzapine, the other background you have to give, and probably change of taxane is something which can be tried. But I would say that giving steroid will not change your efficacy in most of the situation when you are giving in a sequential way, because in sequence you would generally give IO first followed by your all chemotherapy.
So in Keynote 522, another thing they did was they gave IO first, followed by 6 hours of gap, and then the pre-medication and the chemotherapeutic drug.
But there are multiple meta-analysis. So collecting all these studies, they have told that if you are giving in emetogenic dose, it is not going to hamper your efficacy. So it is largely okay, but why not to avoid whenever there is feasible? So
Also,
that makes sense. Why not to avoid?
Also, paclitaxel, there is data enough to show that in the first 2 cycles, you
Then
can
you can
give the
skip.
12 mg,
Yeah.
and subsequently, if patient hasn't had any
Infusion
reaction,
reaction, you
hypersensitivity
can skip
reactions,
giving
then you
dexa.
can
Yeah.
dose reduce to 4 mg.
Even
for them.
there is data to skip dexa in later after 3 or 4 cycles. You can not give dexa for infusion reaction.
I think the one thing is what Dr. Mubina said was with regard to the timing of immunotherapy. Even from a lot of studies have shown that giving immunotherapy before 11 a.m., 12 p.m. leads to a better advantage than this thing because of the chronotoxicity of the T cells and all that. But in India, it's very difficult because that Keytruda free vial will come only after 1 p.m. With that release of OTP and all that. So generally, we have been doing it without any scientific knowledge and just our own this thing that once we give the immuno, we wait about 2-3 hours and then give the dexa dose if we are giving it, and then give the immunotherapy. Waiting for 6 hours becomes this thing. But again, like I said, there are both sides. It's just that at the back of our mind, we do not want to give immunosuppression when we are giving this, but by and large, there are many studies which say that if you have administered the steroid after immunotherapy, there may not be that much detrimental impact, especially if you're not going to 12 mg, 16 mg, but staying at 4 mg, 8 mg.
Okay, so we'll end it. Thank you. Thank you.
Thank you, sir, and thank you to all the panelists.